We move on to the
Okay, sir. Yes, sir. Any doubt from the students? Any questions? We'll move on to the next student, sir. Next question, sir.
next question.
Yeah. Who wants to do it next? Dr. Sai?
Who is presenting?
Good evening, sir.
Good evening.
Myself, Dr. Pankaj Yadav.
Yeah.
I'm presenting, sir, 3 topics. First topic is myocardial protection. Second topic is ERAS protocol. Third topic is pressure support ventilation.
Very good. Okay.
So, sir, myocardial protection. I will start with myocardial protection.
Okay.
It is a technique used during cardiopulmonary bypass surgeries to provide a motionless field, bloodless field for the surgeon. The heart is arrested in diastole by the administration of a potassium enriched cardioplegia solution. And once the surgical procedure is completed, myocardial arrest can be reversed by reperfusing the coronary arteries with warm normocalemic blood. The goal of myocardial protection is bloodless still field for surgeon. Second, protect against ischemic injuries by decreasing O2 consumption and by decreasing metabolic rate. And to protect against reperfusion injury. The ischemic injury which are caused during cardioplegia or myocardial protection, during surgery is that during ischemia, if occurs, it decreases the ATP production. Acidosis, edema occurs, calcium load occurs, and the hypoxanthine dehydrogenase enzyme is accumulated, and cell membranes of is altered. During reperfusion responses, is the mitochondria are destroyed. O2 oxygen free radicals are accumulated due to transformation of the enzyme of hypoxanthine to xanthine oxidase. Next, calcium paradox occurs and cell membrane are destroyed. The first cardioplegic technique was used by Melrose in 1958, in which he infused 2.5% potassium citrate into the aortic root until full arrest is achieved, and the safe period of arrest was 30 minutes. Then reperfusion was done with blood and calcium chloride. Adrenaline and cardiac massage were done at the end. But researchers observed that there was very much myocardial necrosis and poor contractility of the heart were observed. Therefore, for it was done in 1958, and for next 20 years, it was not done, and non-cardioplegic technique prevailed, in which heart was topically cooled and coronary perfusion was done continuously, and intermittent aortic cross clamping was done. But in 1978-79, Follett et al. And Gerald Buckberg compared oxygen consumption in normal hearts, beating decompressed heart on cardiopulmonary bypass, fibrillating hearts, and electromechanically arrested heart. And he concluded that cold arrested heart needs the least amount of energy. Electromechanical arrest has the most protective effect, and fibrillating heart has consumed less oxygen than empty heart always, except at normothermia. In HERS, DJ divided the protection into 3 main elements, into electromechanical arrest, hypothermia, and additive protective agents. He advised that there is for calcium overload and acidosis and adenoma and membrane stability, he advised that some additives should be added in the solution. So he advised magnesium citrate for calcium overload, bicarbonate for acidosis, mannitol or albumin for cellular edema, procaine for membrane instability, and amino acids or glucose to reduce energy substrates and nutrient stores. So extracellular versus intracellular cardioplegic solutions were used. In 1978 or 79, there were 3 or 4 studies experimenting for intracellular or extracellular solutions. In intracellular solutions, sodium concentration as intracellular fluid were used, so it is called intracellular solution. Myocytes remain hyperpolarized, hence it is also called non-depolarizing solution. It has benefit that the corrosive effect of potassium was not there and can can be given initial large dose of 2 liter that sustains arrest for 90 to 120 minutes, and there was no calcium overload. But it has disadvantage also of risk of fluid overload, systemic hyponatremia, and myocardial edema. In extracellular solutions, the sodium concentration was as extracellular fluid, hence it is called extracellular solution, and the extent potential arrest at phase 3, so it is called depolarizing agent. It was given in small doses repeatedly, which interrupts the flow of surgery and prolongs bypass and ischemic time, and it avoids overload risk of intracellular solution. There are two types of solution used for cardioplasia, but on blood cardioplasia or crystalloid cardioplasia. In blood cardioplasia, it was used as an alternative to Melrose solution. It showed better results. In 1978, Buckberg and colleagues started looking for a solution to resuscitate the heart immediately after removing the cross clamp. He used 500 ml of normothermic blood, which enhances the metabolic repair, restores the metabolic function, and replenishes the energy substrate. He used citrate phosphate dextrose to buffer calcium, and trace hydroxymethyl aminomethane to buffer the intra or extracellular buffer that prevents acidosis. And he used potassium, which allows the myocardium a quiescent period, and it also prevents ventricular fibrillation. The blood versus crystalloid solution is that blood cardioplasia has better oxygen delivery abilities due to hemoglobin content, and it has better buffering abilities due to carbonic anhydrase content. It has better free oxygen radical scavengers, provide nutrition to myocardium, and it is physically better flow due to rheological effect. But it has some disadvantages also. It obscures the field for the surgeon. And for crystalloid cardioplasia solution, it was no added effects of blood, but it has linear oxygen dissociation curve, thus no special delivery concentration were needed, and it provided clear better field for surgeon. These solution can be administered in antegrade fashion into the coronary arteries via the aortic route through a needle placed between the aortic cannula and the aortic valve, or in retrograde fashion into the coronary veins via a balloon-tipped cannula placed in the coronary sinus. Antegrade cardioplegic delivery is the most physiological approach. However, when the patient has pronounced CAD or aortic valve insufficiency, antegrade administration may not reach the coronary arteries uniformly, and thus will not adequately deliver cardioplegia to the myocardium. In these instances, retrograde cardioplasia is used. Limitation of retrograde cardioplasia is that it includes the fact that the free wall of right ventricle and the posterior 1/3 of the interventricular septum are poorly perfused by retrograde delivery. Additionally, the microvascular areas of the heart that are perfused by retrograde cardioplasia are less able to sustain normal myocardial energy metabolism. Thus, the most complete technique for myocardial protection involves both antegrade and retrograde delivery. Based on the temperature of solution, they are divided into warm and cold cardioplasia. In warm cardioplasia, the solution is at 37 degrees Celsius, and in cold cardioplasia, the solution is at 4 to 10 degrees Celsius. Warm cardioplasia avoids left shift of oxygen dissociation curve, and if it is delivered continuously, will avoid ischemia or reperfusion injury completely. But it has disadvantages like it increases the O2 requirement by 10 to 20%. In cold cardioplasia, it is relative hypercarbia and acidosis shifts the curve to the right. It has added protective effect of hypothermia, protects against the inadvertent events of interruptions or inhomogeneous distribution, but it has side effects of hypothermia. Based upon the timing of solution delivery, it is at two types, continuous or intermittent. In continuous cardioplasia, there is continuous delivery of solution at low flow. In intermittent cardioplasia, 1 to 1.5 liter of high concentration of potassium is infused out of 20 to 30 microequivalent per liter, and then 200 to 500 ml of low potassium at interval of 20 to 40 minutes of the low concentration of potassium is 10 to 20 milliequivalents. Continuous loss of metabolites is there in continuous cardioplegia, and there is better delivery beyond occlusions. There is no ischemia, only aerobic conditions. Thus, theoretically, safe cross-clamp time is endless. But it has some disadvantages like the blood flow obscures the field, and almost invariably the surgeon will have to interrupt delivery, which subjects the heart to ischemia. But this time, no added hypothermic protection. In intermittent cardioplegia, it has easier setup, and it gives bloodless field to the surgeon. But in between doses, the heart suffers ischemia, and after removal of cross-clamp, reperfusion injury occurs. That's all, sir.
Okay. Previously, the same question used to be asked as cardioplegia and myocardial protection. So mostly you will be writing only about the cardioplegia and other things. But myocardial protection is usually done for cases where you go on a cardiopulmonary bypass and stop the heart temporarily, reduce the supply to the heart. It's creating a imbalance between the supply and the demand. So the only way to protect that myocardium is to reduce the demand, because you are not going to supply your oxygen. So what are all the techniques that you use? One is hypothermia. Second is reducing the requirement of the substrates which are required for normal mitochondrial activity. So to do that only, you go for the cardioplegia and reducing the temperature. All these things are being done. But should you tell something about what is a hibernating heart and a stunned myocardium?
Exactly, sir. Hibernating
Yeah.
heart, anesthetic preconditioning. So I think
Yes, sir.
kind of
That also to be included in your answer. Okay. So because you are stopping the heart.
Hibernation, myocardial hibernation is known when the ischemia or injury is for prolonged time, but it is mild, and the myocardial cell adapted itself to the injury, and it reduces in its own
What is the basic
oxygen consumption.
difference between hibernation and
Stunning.
stunning?
Sir, in stunning myocardial injury, it is for short period and of severe. And in
What about the
myocardial
blood supply?
blood supply is
Can it happen even in patients suffering a myocardial infarction? When there is a coronary artery disease,
Yes,
can
sir.
the terminology of myocardial stunning and hibernation happen in those patients, apart from those who are undergoing cardiopulmonary bypass surgery? Even in patients suffering from myocardial ischemia and infarction, these terminologies are used. In that case, how do you define, or what are the characteristics between these two conditions?
Sir, in myocardial hibernation, heart goes into the adaptive state. It requires less
Yes.
energy. Revascularization occurs, but
Yes.
it again lead to the normal heart functions. But in stunning, reperfusion injury occurs in myocardial stunning, and normal revascularization doesn't occurs of that
What
area.
happens to the contractility? See, that is what will happen. Whenever you stop the blood supply to the myocardium, within how many minutes it will stop contracting? What is the time duration?
It's a 90 to 120
Maximum
minutes.
20 seconds. 20 seconds.
20 seconds.
Okay? So it will
Okay, sir.
stop contracting so fast. So that is our main problem. Unless they start contracting again after a prolonged period of ischemia, you will have akinesia or hypokinesia of that particular segment. So we are worried about re-establishing the contractile nature of the myocardium. So that is why we are taking so much of precaution to get it back to the normal method of metabolism, aerobic metabolism, so that they can have okay. So that is what the main thing that we are worried about. So
What is anesthetic preconditioning of the myocardium? Just completion. What drug?
that is, yeah, all the volatile anesthetic agents also produce. So I will show PPT where these points are little highlighted. Whatever points you have written are all very correct for this answer. But can I share the screen?
Yes, sir.
Screen visible now?
Yes, sir.
Yes, sir,
Visible.
not visible, sir, not full screen, sir.
Huh?
Yes, sir.
Visible, okay. So first you define what is myocardial protection. So refers to strategies and methodologies used either to attenuate or prevent post-ischemic myocardial dysfunction. That is the main aim of myocardial protection. Refers to strategies and methodologies used either to attenuate or prevent post-ischemic myocardial dysfunction that occurs during and after heart surgery. Any heart surgery can produce that. Even your beating heart surgery, if you will handling, you will be decreasing the blood supply to the some portion of the myocardium. When you apply the octopus clamps also, you will be to some extent affecting the blood supply. So open heart surgery or any other heart surgery, it can happen. And the pre-CPB hemodynamic stability is very, very important. Cardioplegic techniques that you use, and success and adequacy of surgery, separation from CPB, hemodynamic stability in the postoperative period, or pre-existing systemic and myocardial diseases. All these things have a major role or important bearing in the myocardial preservation. And adult versus pediatric, coronary artery disease versus valvular heart disease, pre of hemodynamic stability, these are all preoperative factors. Ischemic or infarction already present. The patient has arrhythmias or hypotension. And intraoperatively, what is the type of anesthesia that you give, whether the patient goes in for any hypovolemia, LV dysfunction, arrhythmias, tachycardia, hypertension, inadequate ventilation, or direct manipulation of the heart, mid-cab or OPCT, all these are intraoperative factors. And adequate ventilation, avoid ventricular distension, avoiding vasospasm, maintaining hemodynamics, controlling bleeding, and maintain coronary blood flow. All these things are very important in the immediate post-op period also. Now, what are the basic principles of adequate myocardial protection? Include rapid induction of arrest and mild to moderate hypothermia, appropriate buffering of cardioplegic solution, avoidance of substrate depletion, and attention to intracellular edema. These are the 5 things which you have to keep in mind doing myocardial protection. So, how does the high potassium load able to cause this arrest? We commonly say diastolic arrest. The mechanism is as the extracellular potassium concentration increases, the resting myocardial cell membrane becomes depolarized. The voltage dependent fast sodium channels are inactivated. This is the main thing, arresting the heart in diastole. The slow calcium channel is activated, resulting in cytosolic calcium overload. So the 2 things that happen are inactivation of the fast sodium channels, which are very important for contraction, and the increase in the cytosolic calcium load, and the concentration of potassium we need is 15 to 40 millimoles per liter. So this picture will show that the arrest can be either a polarized or a depolarized arrest. And polarized channel and its phone is getting into the range. And am I audible?
Yes, sir.
Yes, sir. Yes, sir. Audible, sir.
The battery is running down. power. Okay, quickly I'll finish. So the depolarized elevated potassium causing inactivation minus point sodium channels, whereas in polarized ferrous it causes the activation of potassium channels to exclude the potassium, and inside you find the calcium load is decreasing entry. So all these things result in the relaxation or the diastolic arrest of the heart. So polarized arrest, sodium channel blockade and potassium channel opening both happens, whereas in depolarized arrest it accumulation, calcium accumulation inside. So the mechanisms of myocardial ischemia: depletion of high energy phosphate, intracellular acidosis, alteration in intracellular calcium, direct myocardial ischemia, oxygen derived free radical generation, and myocardial edema. And cessation of flow affects mitochondria and cytosol. So all these changes, anaerobic glycolysis happens. So depletion of cellular ATP is the ultimate result. And the oxidative phosphorylation, which produces the maximum amount of ATP, that is also not taking place. So ATP depletion occurs. That is the basic thing that happens. So when depletion of ATP is less than 50% of normal, you get irreversible lethal cell injury because glycolysis is blocked, cellular acidity is there, protein denaturation, nuclear changes happen. So factors contributing to reperfusion injury or calcium influx into the cell, generation of free oxygen radicals, neutrophil activation and complement activation. Now, what are the manifestations when you start reperfusing? Reperfusion dysarrhythmias, post-systolic and diastolic dysfunction, myocardial necrosis, endothelial dysfunction, apoptosis, edema, and microvascular injury. And how do you minimize all these things? Decrease extracellular calcium, addition of antioxidants like superoxide dismutase and glutathione, controlled reperfusion, and monitor also to scavenge the free radicals. And myocardial protection encompasses strategies employed during pre-operative phase, operative phase, and post-operative phase, which I showed a little earlier. And the types of crystalloid and blood, each one has got their own advantages and disadvantages, which were all very well described by Dr. Yadav. And coming to this hibernation and stunning, normally coronary stenosis up to 40% does not affect the maximum coronary blood flow. That is, even if you do exercise, there will be blood flow going to the heart. Between 40 and 80%, this excess maximum flow will not happen, but the resting flow is normal. If the person, when he exercises only, the oxygen, the blood supply is reduced. But at rest, the blood supply remains not normal. When stenosis exceeds 80%, restricting even the resting blood supply is affected. So myocardial stunning and hibernation appear to be part of the same clinical spectrum, only varying in degrees. That is the main thing. The difference between stunning and hibernation is that in the stunning, the resting coronary flow is unaffected, and in hibernation, it decreases. And chronically dysfunctional myocardium would be termed as hibernating. So repeated stunning happening results ultimately in hibernating myocardium. So in the hibernating myocardium, there is a moderate to persistent reduction in myocardial blood flow, causing diminished regional contraction. So non-contractile myocardium will be there, and metabolic process remains intact because it's viable. You can, once you establish the perfusion, it can come back to normal. Decrease in magnitude of the pulse of the calcium involved in the excitation contraction process. So inadequate calcium levels in the cytosol during each heartbeat happens. Whereas in the myocardial stunning, function of the myocardium remains impaired for a certain period despite re-establishment. Full recovery is expected. Process occurs over a period of 1 to 2 weeks. The contractile proteins recover if the myocyte is reperfused before irreversible damage happens. So these are two stages of the same spectrum. Both the primary problem is ischemia, and the secondary problem is how the proteins are getting affected and whether it can come back to normal contractility or not. That is the major thing that you have to remember. Okay, so that is the 2 points that I thought I will add to that. Okay. Can we quickly finish the other one?
Sir, my next topic is ERAS protocol. ERAS is enhanced recovery after surgery, which is an evidence-based multimodal perioperative protocol focused on stress reduction and the promotion of return to function. It challenges strong traditional beliefs like NPO from midnight, mechanical bowel preparation, nasogastric tubes, use of drains, prolonged fasting in post-operative period, and mobility restrictions. It was initiated by Professor Henrik Kahlet in 1990s for colorectal surgeries, but nowadays it is used in many GI and other surgeries. It reduces the stress response to surgery. It reduces the care time for more than 30%, or after major abdominal surgeries, it reduces the more than 2 days post-operative day time for in hospital. It reduces complications up to 50%. It has preoperative, intraoperative, and postoperative branches. In preoperative, the information, education, and counseling should be given to the patient. Detailed information should be given to patient before the procedure about surgical and anesthetic procedures. This will diminish fear and anxiety and enhance post-operative recovery and quicken the hospital discharge. All patients undergoing elective surgery should be counseled. Clear specific instruction about mobilization, diet, exercise, daily target for patient to achieve should be set up. Patient should be provided with verbal and written information. Then prehabilitation is the process of enhancing an individual's function capacity to enable him or her to withstand a forthcoming stressor of major surgery. Rehabilitation is a multimodal approach encompassing medical optimization, preoperative physical exercise, nutritional support, and stress and anxiety reduction. For preoperative training, as muscle strengthening exercise should be given daily for 1 to 2 kilometers per day bicycling for 30 to 45 minutes. They should practice deep breathing exercises, yoga, pranayam, and should use incentive spirometer at least 25 breathing exercise each time for 3 times a day. Alcohol and smoking should be stopped 4 to 6 weeks before surgery. For nutritional support, patients should be screened for nutritional status and those at risk of undernutrition given active nutritional support. A low body mass index has a significant better predictor of post-operative mortality risk than cardiopulmonary exercise testing. For preoperative carbohydrate loading, it decreases insulin resistance and it increases carbohydrate uptake, utilization, and storage. It decreases protein breakdown and catabolism. It promotes anabolic state and it causes 20% decrease in length of stay in hospital and 50% decreased insulin resistance and 50% less loss of lean body mass. Preoperative fasting and carbohydrate treatment. Recommendation is fasting for 6 hours to solids, clear fluids up to 2 hours before GA, and clear carbohydrate rich drink of 120 grams should be administered orally night before surgery and 2 to 3 hours prior to induction of anesthesia. In diabetics, carbohydrate treatment can be given along with diabetic medication. For bowel preparation, earlier bowel preparation was done in GI surgeries. It causes dehydration. It increases spillage of bowel content. It prolongs ileus, and it has no added benefits in anastomotic leak or infection after surgery. So recommendation is it should be not routinely required. If clearance of rectum is required for left-sided anastomosis, then enema should be given. For pre-anesthetic medications, recommendation is not routinely recommended before surgery because it causes psychomotor retardation in the first 4 hours of recovery. But if required, short-acting IV drugs to facilitate administration of epidural or spinal analgesia can be given. For thromboembolic prophylaxis, compression stockings and DVT pumps prevents venous stretches. So it is recommended in all patients to wear it. Low molecular weight heparin prevents thrombosis. So it should be given once a day or twice a day. Antibiotic in intraoperative antibiotic prophylaxis and skin preparation. Routinely should be given prophylaxis of antibiotic and covering both aerobic and anaerobic organisms to be administered 30 to 60 minutes prior to incision. Repeat dose should be given if procedure more than 4 hours is there. Skin preparation with chlorhexidine alcohol should be done. Hair clipping is associated with fewer surgical site infection than shaving with razors if hair removal is necessary before surgery. Standard anesthesia protocol recommendations is using short-acting induction agents like propofol, short-acting opioids like fentanyl, L-fentanyl infusions, short-acting muscle relaxants, and should be used and should be titrated with neuromuscular monitoring. Short-acting inhalational anesthetics like Sevo or DES with oxygen-enriched air should be used, or TIVA using PCI pumps, especially in patients with PONV. Surgery, laparoscopic surgery is recommended if the expertise is available. It has advantages of reduced post-op immunosuppression, reduced complications, and reduced hospital stay. For post-operative nausea vomiting, multimodal approach should be given in like ondansetron, metoclopramide, or diphenhydramine should be used if FPEL score is more than 2. FPEL score is for PNV it has 0 to 4 rating. If more than 2, it should be multimodal approach should be used. For nasogastric tube, it causes atelectasis and pneumonia more frequently in patients with nasogastric tube. Bowel function returns earlier in patient if nasogastric decompression is avoided. So recommendation is it should be avoided. So for preventing intraoperative hypothermia increases bleeding, wound infection, and adverse cardiac events. So systemic warming 2 hours before and after surgery is recommended. For monitoring temperature, active warming should be done till temperature of more than 36 degrees Celsius. Perioperative fluid therapy, intraoperative fluids, colloids, and crystalloids guided by flow measurements to optimize cardiac output should be done. Esophageal Doppler device targeted fluid on individualized basis. CVP should not be used only for fluid guidance, and vasopressor should be used for hypotensive normovolemic patients. Balanced crystalloids should be used. The goal of perioperative fluid therapy is to maintain fluid hemostasis, avoiding fluid excess and organ hypoperfusion. Avoid fluid excess leading to perioperative weight gain more than 2.5 kg and target a perioperative near zero fluid balance. Epidural analgesia and local blocks. In open colorectal surgery, we should give epidural analgesia at the beginning of procedure and should maintain it for at least 48 to 72 hours after the surgery. We should give local anesthesia with low dose of opioids. Care should be taken that the equipment does not interfere with the mobilization of the patient. Tab blocks can be given in patient, and if possible, laparoscopic excision should be done. For preventing ileus, mid-thoracic epidural analgesia should be given. It prevents ileus and it is routinely recommended. For fluid overload and nasogastric decompression, it delays GI function, so it should be avoided. Oral magnesium and alvimopam opioid-based analgesia stimulates GI function, so it is beneficial and it is recommended to give. Chewing gum enhances motility of the GI tract, so it is recommended in preventing ileus. For post-operative pain management, multimodal analgesia approach should be given, like NSAIDs, IV lignocaine, opioids, gabapentinoid, and alpha-2 agonist can be used. Avoidance of opiates and use of PCM and NSAIDs. PCM and NSAIDs such as ibuprofen or diclofenac should be given if no contraindication. Opioids, including codeine, tramadol, be reserved for breakthrough pain, with opioids measures to prevent nausea and vomiting and regular antiemetics to be prescribed. For post-operative sugar control, Hyperglycemia causes wound infections and delayed recovery. So it is recommended that we should avoid hyperglycemia, and insulin should be given to control hyperglycemia in post-operative period. So till now, the length of hospital stay and post-operative complications were there. ERAS was proposed to decrease the length of hospital stay and decrease the post-operative complications. But roadblocks for routine ERAS is that there are too many components in ERAS. There is lack of standardization. There are limited resources in developing country. Lack of data on long-term effects. Adherence and compliance to protocols is very difficult. Logistic issues are there, and most studies incorporated only a portion of the ERAS template, not all elements. So summary is that the paradigm shift is in how perioperative care is delivered in ERAS. Current problem that are being discussed by ERAS proponents include barriers of implantation. So whenever it is possible, we should we should follow ERAS protocol. Thank you, sir.
Very good, excellent. So, but what I feel is that you can start saying that ERAS involves multidisciplinary approach, and it can be divided into pre-op preparation, intra-op management, and post-operative care. That if you can classify that, then mention all the points that you have mentioned there under these headings, that we make a better presentation. And there are diagrams available which can be just written to avoid lengthy paragraph writing. And it can be in the form of central ERAS with branching or radiating points, or it can be in a flow chart like that. I just like to show those two charts alone, so that you can Is it visible?
Yes, sir.
Okay. So these are the two ways you can easily present that. See, one is this central, you can show this ERAS here, and then what is the pre-admission counseling and patient engagement, fluid loading, no pre-med, no NG tubes, short-acting anesthetic agents, avoidance of sodium and fluid overload, minimally invasive surgery, only one drain, warm air body heating during procedure, early mobilization and respiratory physiotherapy, non-opioid patient management, pain management with NSAIDs, perioperative oral nutrition, prevention of nausea and vomiting, early removal of catheters, audit and compliance. So if you just draw these pictures and remember all these points, 1, 2, 3, 4, 5, 6, like that, it will be easy to draw and then finish your answer and save a lot of time. Other method is to go for pre-hospital phase, where you can say patient family education, pain management plan, patient organization, rehabilitation, and selection of patient. This is very, very important. So you must choose your patient for ERAS protocol, and pre-operative phase, limit fasting, carbohydrate loading, initial multimodal medications, discharge planning, education at home, and medical plan. All these things have to be done pre-operatively. Intraoperative phase, you can say opioid sparing, multimodal analgesia, normovolemia, nausea, vomiting prophylaxis, normothermia, normoglycemia, avoid tubes and drains. Then post-operative phase, early nutrition, early mobilization, multimodal analgesia, nausea vomiting management, judicious use of IV fluids, and patient and family education. And post-discharge phase, monitor symptoms, follow up with surgeon, proceduralist, continued therapy, and other professional activities. So then continue quality improvement team activities also once you start planning or practicing EROS. And as you rightly said, it was originally started by Professor Kellogg for colorectal surgery. But nowadays we have EROS protocol being followed by many other branches. Thoracic surgery EROS is there, neurosurgery EROS is there. So nowadays the EROS has become a component for all the surgeries. This is becoming more and more popular because of shorter hospital stay and lesser amount of complications. Okay, so these things can be easily finished off by making these type of flowchart or the other method of writing rather than writing too many sentences to save your time in the examination, especially if it is a short note question. You are running short
Okay, sir.
of time after writing many answers. This can be used easily to present all the points that you have mentioned in sentence forms.
Okay, sir.
Right.
My third topic is pressure support ventilation.
Okay.
Pressure support ventilation is a mode of positive pressure mechanical ventilation in which the patient triggers every breath. It is deliverable with non-invasive or invasive mechanical ventilation. It is a very comfortable for patient and is a very useful ventilator setting for weaning off from invasive ventilation and for providing supportive care with non-invasive ventilation. Flow delivery is by setting a driving pressure. The flow delivered will be dependent on the set driving pressure, airway resistance, lung compliance of the patient, and inspiratory effort of the patient. The breath is flow limited, meaning that the driving pressure terminates when the flow decreases to a set percentage, usually 25% of the peak flow. Tidal volume delivered is dependent on the flow and the duration of the inspiratory phase. Settings for PSV mode include driving pressure, positive end expiratory pressure, and the fraction of inspired oxygen. Minute ventilation is dependent on the patient's respiratory rate and the tidal volume delivered with each breath. No mandatory breaths are given in PSV, thus no minimum minute ventilation is ensured. Indications of PSV. Pressure support ventilation is used to deliver oxygen and support ventilation in patients with hypoxemic, patient hypercapnia, and mixed respiratory failure, and for weaning off from the invasive ventilation. It is also used to perform a spontaneous breathing trial. The flow delivered by the driving pressure can provide a tidal volume and minute ventilation higher than the patient could achieve without ventilator support. This higher minute ventilation improves oxygen delivery and carbon dioxide offloading. PEEP improves oxygen delivery by keeping distal airways and alveolar sacs open during the expiratory phase, improving ventilation perfusion matching in the lungs. Also, there is reduction in oxygen consumption by decreasing the work of breathing of the patient. Contraindications. It is contraindicated in depressed respiratory drive, very high oxygen consumption, elevated airway resistance, patients with neurological disease, encephalopathy from critical illness, or those receiving sedation because they may hypoventilate. The work of breathing and thus oxygen consumption is higher in PSV than in control mode of ventilation. It is contraindicated in patients with shock or low cardiac output because they may need more respiratory support. It is also contraindicated in high airway resistance because in patients with obstructive lung disease, and because obstruction limits peak flow and can result in small tidal volume. Advantages of improved patient and ventilatory synchrony, increased patient comfort, minimal or no sedation may be required in this mode, minimal cardiovascular effects, patient retains control over his frequency, inspiratory flow and time. Disadvantages, minute volume is not guaranteed. Large changes in patients' breathing may occur without changing the actual minute volume. Periods of hyperventilation may occur. and increase work of breathing if inappropriate rise time or trigger settings are there. And that's all, sir.
So this is a mode which is mainly used for what purpose?
So
For
weaning off
weaning
from
without disconnection. Without disconnection. In earlier days, whenever we want to disconnect, wean a patient from mechanical ventilation, we used to abruptly disconnect them, assessing the negative pressure reading that is going on in the airway pressure monitor. If it is more than 2 centimeters, we used to clinically observe how this breathing pattern is and then disconnect them from ventilator and just give some supplemental oxygen and observe him for 1 or 2 hours. If he doesn't go in for tachypnea, sweating or tachycardia indicating that he is going for hypoxemia, we used to extubate the patient. Whereas to avoid that period where there is a possibility patient can go in for hypoventilation and hypoxia, ventilators have incorporated this pressure support where it helps and gives pressure to the patient's own spontaneous respiratory efforts and reduces the work of breathing and tries to wean him without abruptly disconnecting him from the ventilator. That is the most important thing that is happening, and all the other points that are all mentioned. That answer is sufficient for short note question.
Thank you, sir.